So today we'll be talking about a very interesting comparison between telmisartan and the cilnidipine. Now, telmisartan, as we know, is angiotensin receptor blocker. Now, angiotensin is a part of renin-angiotensin-aldosterone system, and angiotensin is one of the most potent vasoconstrictor. So, this angiotensin 2 very commonly causes significant vasoconstriction. That is the reason for the high blood pressure. So, this telmisartan is an angiotensin receptor blocker, so automatically it acts on this renin-angiotensin aldosterone system and it helps to reduce the blood pressure. Whereas cilnidipine is a calcium channel blocker and they act through the vasodilation because these calcium channel blockers actually block the calcium channels in the blood vessels where we have vascular smooth muscles. So because of the blocking these calcium channels, this vascular smooth muscle gets relaxed, causing vasodilation, and hence it reduces total peripheral resistance, that is TPR, and it causes fall in blood pressure. This telmisartan, they very commonly enhance the diuretic action also, and the peak action of this telmisartan is achieved over a period of 2 to 4 weeks. Same is with the cilnidipine. It takes around 2 weeks for its peak action, so that once the medicine is started, the effect of blood pressure lowering improves over a period of time over 2 to 4 weeks. The good thing about the telmisartan as well as the cilnidipine is that they are remarkably free of much side effects. So telmisartan, apart from the hyperkalemia, telmisartan as it blocks angiotensin receptor, is very commonly tend to cause increase in serum creatinine, especially if the serum creatinine is high. So whenever there is high serum creatinine, especially above 1.5, then there can be significant tendency of rapid increase in serum creatinine and which may lead to hyperkalemia. So if serum creatinine is usually more than 4, telmisartan is never started, and if the serum creatinine is more than 1.5, it is very cautiously used. And exactly opposite is the cilnidipine. Cilnidipine is perfectly safe in CKD, and that is the reason why cilnidipine is very commonly used to control the high blood pressure in even stage 5 CKD patients, where cilnidipine is very commonly used up to 40 milligram per day, as there is no risk of this hyperkalemia, so it is safe in CKD. Whereas telmisartan is not safe in CKD, it is not at all used if serum creatinine is more than 4 because there is marked increased risk of hyperkalemia and patient may die suddenly. Apart from that, this telmisartan does not increase levels of kinin, so there is no cough, angioedema, or urticaria, which is very commonly seen with the ACE inhibitors like ramipril and enalapril. But the good thing about the telmisartan, which is not usually seen much with cilnidipine, is telmisartan reduces the diabetic nephropathy. Telmisartan reduces proteinuria. This proteinuria reduction is also seen with cilnidipine. So cilnidipine also reduce the proteinuria. So this has some beneficial effect on CKD progression when it comes to cilnidipine. And when it comes to telmisartan, it has excellent role in retarding the diabetic nephropathy, hypertensive nephropathy. It reduces the proteinuria, hence reduces the progression towards the chronic kidney disease. It reverses left ventricular hypertrophy. So overall, it reduces the shortness of breath, dyspnea. It reverses the vascular hypertrophy, and hence, by these two main actions, it also improves the cardiac mortality. So, this much benefit, the reversing of LVH, the reversing of vascular hypertrophy, is not much seen with the cilnidipine here. So, in this perspective, telmisartan is much more superior medicine when it comes to reversing LVH and reversing the vascular hypertrophy and improving the cardiac mortality. This improving cardiac mortality, reversing LVH is not seen with cilnidipine. So definitely by doing these things, it definitely reduces the hospitalization risk for heart failure, especially in those patients who had earlier heart attacks or those patients who has multiple risk factors. That is the reason why telmisartan is one of the first line medicine for hypertension, which is very commonly initiated first. And the usual dosage is around 40 to 80 milligrams per day. And most of the time, single oral dosage is sufficient. Nowadays, we have combination of telmisartan with cilnidipine. There are so many medicines which have single tablet containing telmisartan and the cilnidipine as well. Coming to the cilnidipine, this ankle edema, which is a very common feature with amlodipine, is not much seen with cilnidipine. In fact, the patients getting amlodipine very commonly are switched to cilnidipine if the patient has pedal edema, because the pedal edema or ankle edema is not much seen with cilnidipine. This medicine also is very commonly given once or twice a day. Once a day also many of the times suffices. And the action is independent of the renin status. There is no compromise hemodynamically, so which is very commonly seen with the diuretics, because diuretics cause so much of diuresis and there can be significant hemodynamic changes. The cilnidipine is perfectly safe in asthma. Same with the telmisartan. In acute asthma or COPD, beta blockers are very commonly problematic because they can increase the bronchospasm. But with the calcium channel blocker or with the telmisartan, they are safe in asthma. They won't increase the risk of asthma exacerbation. There is no impotence or sexual disturbance which is seen with cilnidipine, which is very commonly problem with again beta blockers. Beta blockers very commonly have this side effect. And cilnidipine or amlodipine, these are considered compared to safe in pregnancy because they usually don't have any adverse fetal outcome, whereas this telmisartan is absolutely contraindicated in pregnancy and it is not at all used in pregnancy. This reflex tachycardia is not a feature of cilnidipine, whereas this is a feature with amlodipine. Amlodipine very commonly causes reflex tachycardia. That is the reason why any patient having acute coronary syndrome or MI or NSTEMI or STEMI, if they are given with amlodipine, there may be increased risk of arrhythmias or death because of reflex stimulation and reflex tachycardia. But in cilnidipine, in fact, there is reduction in the heart rate. That is the reason why those patients who may have slightly higher heart rate with the high blood pressure do benefit from the cilnidipine. As we have said that the cilnidipine does not help for left ventricular hypertrophy or cardiac mortality, whereas this telmisartan significantly helps to reverse the left ventricular hypertrophy and it also reverses the vascular hypertrophy. That is how it improves the cardiac mortality over a long term. And as I said earlier, it is safe in CKD. There is no hyperkalemia, and up to 40 milligram per day can be used in CKD patients. But most of the time, around 10 to 20 milligram per day in most of the hypertensive patients suffices. There is one good quality of cilnidipine is it causes increased uric acid excretion. That is how it reduces the uric acid in the blood. So those patients who have high uric acid levels can be started on cilnidipine instead of telmisartan, because telmisartan won't help for uric acid. It won't reduce uric acid level. So patient may need to take any other medicine to reduce the uric acid. Whereas if the patient is getting cilnidipine, the uric acid levels may reduce with cilnidipine only. So if someone has hypertension with hyperuricemia, then that patient can be put on cilnidipine instead of telmisartan, and it can benefit for both high blood pressure as well as to reduce the uric acid levels as well. So this was all about, and thank you so much.